Improving length of stay by targeting provider variation is our episode topic. My guest is David Broussard, a registered nurse and managing consultant in BRG's Care Transitions team. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
David, thank you so much for joining us today.
Absolutely. My pleasure. Thank you for having me.
Before we get into our episode topic, can you share a little bit about yourselves with our listeners?
I'm a registered nurse. My clinical expertise ranging from critical care, cath lab, and then moved into hospital operations and oversaw several departments in an acute care facility. And from South Louisiana.
Our topic today is improving length of stay by targeting provider variation. And let's get into the weeds a little bit here and talk about what exactly is provider clinical variation. What are we talking about when we hear those words?
We're talking about the inconsistencies in treatment plans, patient care plans, length of stay management, patient throughput that providers can affect or have a say in. We all know today's environment, hospital margins are tighter and tighter. Everybody's looking at how to reduce cost. Provider variations can help, or lack thereof, can help with that, as well as improve length of stay, patient throughput. Provider variations, it's about over and underutilizing resources that affect the inefficiencies or that would allow efficient patient progression on a daily basis to improve their overall hospital length of stay. And what I mean by over or underutilizing our resources, it's those resources that are utilized that may be deemed maybe unnecessary, duplicative, repetitive, maybe some defensive in nature from a defensive practice perspective. Some providers understand the amounts, how financial and how healthcare is impacting their patients, and they may want to help them cost contain by doing procedures or more imaging or more testing while they're in the hospital. Also making sure that they want to develop that patient nurse, that provider patient relationship so that their patients can request them again or come see them again. So by doing more testing, not necessarily inappropriate, but unnecessary testing in the acute care hospital setting is what all contributes to provider variation.
What exactly are we talking about? We're talking about, you mentioned tests a couple of times. So repeat CAT scans, repeat studies that aren't necessarily related to the diagnosis for admission. Are those part of it, or is there more to this than that?
All the above. And it's about what we like to have this phrase, while you're here. It's about trying to dissuade providers from, oh, while you're here, let's do X. Or while you're here, I know you're in for pneumonia, but you had that rotator cuff injury. Let's see if we can do the MR of your shoulder while we're here. Or I normally do a CAT scan follow-up from the office, but I can do it while you're here, so that would be easier. Or from just AM lab work perspective, do you need daily AM lab work every day of every admission? Do you need that extra chest x-ray? Do you need that MR that could be done as an outpatient or at another post-acute care setting? That's more or less what we're discussing.
Okay. And just to play the devil's advocate for a moment, certainly doing something like that, we're in a consumer-centric healthcare industry right now. And gosh, if I'm being admitted for pneumonia and I have an opportunity to get my MRI for my rotator cuff, why not do that? Why is that a bad thing?
Because number one, it's prolonging patients' length of stay. It is adding cost to that ever so desired admission, right? Hospitals need inpatient admissions.
Yeah.
But adding cost to that admission and adding more, and I'll use the word unnecessary for this example, but adding more unnecessary work to that MRI department. So then now you have an MRI staff that has to do an inpatient MR instead of maybe an outpatient MR. You have to have that MR read by a radiologist. Then you have to have it documented. Then you have to have the results back to the patient in a timely fashion, which is more than likely going to extend that stay at least a day or so, depending upon the facility and the time of day that the MR is ordered. All that contributes to extension of length of stay, extension of cost of care, and it also occupies that patient is occupying the bed that someone else is probably needing to get into. In today's world, everybody is in the ED. All the EDs are exploding. And how do we make sure that we have beds for all those patients who require admission to an acute care facility?
Yeah, it's not just getting the MRI, to your point, it's about getting it read. And if I were to get it on an outpatient basis, I could probably get the result in 2 or 3 days. I don't necessarily need to have it before the next thing happens, which in the inpatient world is hopefully a discharge. How can provider variation affect length of stay management? Really, what is you alluded to it a little bit. What are the downstream effects from provider variation on length of stay as a whole?
So once again, length of stay affects most of every aspect of hospital operations, right? So you have a patient in the bed, and then that patient comes in with a diagnosis, and a treatment care plan is established. What we would hope would be done is upon admission, diagnosis and treatment is developed, plan of care is established, and then that is communicated to the patient, the family, the care team, and care is provided in the acute care setting as long as the patient needs to be in the hospital. But what can happen with provider variation is once the diagnosis is established and a treatment plan is created, then going off script, so to speak, it allows that length of stay to expand. We have to understand the fact that there are going to be some patients that show up at our facilities and need a variety of issues treated acutely. And I think the operative word here is acute care setting. What needs to happen in an acute care setting versus what can be transitioned to that post-acute world, whether it be outpatient testing at an imaging center or a freestanding lab, or maybe even at a post-acute facility, whether it's a rehab facility or a skilled facility. Understanding that we want to acutely treat our patients, and then we want to transition them to that next level of care after providing that high quality care as soon as possible.
So we've talked a little bit about why care variation is a problem, how it's impacting length of stay. If I'm a leader in an organization or in a chief nurse role, or maybe I have oversight over case management, and I know that we've got provider variation that's going on, or perhaps I want to understand to what degree is provider variation on, where do I start? What do I do? What's my next steps to assess provider variation in length of stay?
I think the first thing everyone needs is trustworthy data, right? We need data that is factually based, unbiased, and that our providers can trust, because our providers are highly functional, highly educated, and highly driven to provide care for the patients that they serve. So if anyone, provider or otherwise, is going to perceive that we're trying to put restraints on that particular care, then you'll lose the provider. You'll lose them to any advancement or any positive outcomes that you're trying to address from a provider variations perspective. So data mining and data management is important. How do we address variations from a data perspective? There's lots of tools out there. We like to utilize is all things length of stay. We address from a GMLOS perspective on a DRG basis. We look at length of stay by service line. We look at length of stay by provider. We look at length of stay by physician group. We also can look at order entry, how much lab work is being ordered per patient, how many consults are being ordered per patient, per service line, per disease management, per DRG. We like to look at and apply all that criteria we look at an OE ratio, for example, observed versus expected. And then you compare all of that information and data to a service line perspective, to a peer-to-peer perspective. Having data transparent but understood is very important as well. So there's lots of data you utilize to first perceive if you have that care variation problem.
All right. So getting data is often a difficult challenge with the clients that we're working with. And as you start to tease out that data, I think clearly if you have a patient that's being admitted to a surgical service, it's very clear to understand what the length of stay may be and who that provider is. But when you're more on an a family medicine, internal medicine, hospitalist side of things, patients may receive care by multiple providers over the course of their hospitalization. So, how is that attributed? What process do you utilize to attribute the visit to the length of stay for that provider? Is it based on the admitting provider, the discharging provider, a combination of both? What's the secret sauce there?
We can look at all of the above, right? What we look at is the discharging provider. The data is attributed to the discharging provider.
Okay.
And that data, and the first thing you'll hear from providers is, well, I absorb certain patients from my colleagues, and then I'm getting tasked or attributed their long length of stays or their variations to my data, which is a great comment. But also, if you look at it from a chronological perspective or a over time perspective, that all evens out.
How does this work when you're working in a hospital and you're working in environments where you have multiple providers that are caring for patients over the course of their hospitalization? I get admitted as a patient on Sunday, and let's say that at this particular hospital, all of the hospitalists turn over on Tuesdays. So I'm responsible for provider A on Sunday and Monday, and then another provider on Tuesday. Or better yet, let's say that I get admitted on Wednesday and I come around and I get discharged the following Tuesday by the new provider group, right? They see me on the first day and they're discharging me and they're like, I'm taking the hit for a 7-day length of stay when I would have discharged this guy back on Friday. How do we attribute that and work that out to a mechanism where, to your point, trust needs to be established for providers to buy into the feedback and the validity of the data?
And from that provider who's absorbing that long length of stay, we would hope to exactly your words, we would hope that provider would have that conversation with his colleague. Hey, listen, I follow you every Tuesday. We swap out. We're on the same service line, and I'm absorbing these long, lengthy patients where I see there could have been an opportunity to shorten the length of stay. We would applaud to have that conversation be had between providers. The other thing is by attributing to the discharging physician over time, those long length of stays combined with those short length of stays, it'll all average out over time. So as one provider may sense that they're getting dinged for absorbing other cases, nope, all patients are created equal, right? So that provider who happens to be a high performing provider ultimately will have those exceptions and those patients that come in with multiple issues, with multiple acute issues and need multiple things done. That patient's going to stay longer probably than another patient. Once again, we look at a GMLOS, we look at a DRG, and of course, those are mathematical calculations, right? Some patients stay longer, some patients stay shorter. So that's the same for the attributing physician upon discharge. Over time, it'll all be adjusted out, and you get a great picture of how a provider is caring for their particular patients.
Talk to me a little bit about the importance of trust and transparent relationships with providers as you're working through a data-driven scorecard process.
That is probably the most important aspect. They have to understand that you understand the world they live in, you understand the work that they do, and then you have to be able to communicate to them that understanding. At the same time, showing how opportunities for improvement are there and that they will not impact their patients' outcomes. Having data is great and wonderful, but making sure that the data that you're articulating back to the provider, they can understand, they can trust that data, they trust the person giving them that data.
How often should this data be reviewed? What's the regular frequency with which you examine data for length of stay at an individual provider level?
So from a provider level, we look at it monthly. The number of discharges, it will have the length of stay attributed to those discharges. It'll have that OE ratio that allows the providers within that group to see how the whole group is doing.
And just
And
for
you
the
can also
benefit of everyone that's listening in, what is an O to E ratio?
observed length of stay versus expected length of stay. That expected length of stay comes from what DRG attached GML is attached to the DRG, right? From a simple pneumonia perspective, if that GMLOS is 3 and the observed length of stay was 4, then you're not gonna have a one-to-one relationship as we would hope as the ultimate goal is GMLS of 3, acute length of stay of 3. Patient was discharged on day 3 with a ratio of 1.
So if it was 4 days and the expected was 3, it would be 1.3 then basically, 1.33?
Correct.
And then you said GMLOS. What's GMLOS?
Each diagnosis comes with a diagnosis-related group, a DRG, correct? So,
Right.
for instance, pneumonia. There's 3 levels of pneumonia, for the most part, that patients can be admitted to an inpatient facility and get attributed to. These 3 levels, these 3 DRGs are assigned a geometric length of stay to each. We get that from the federal government, right? They establish what that geometric mean is for each level of pneumonia. And then we utilize that geometric mean because that's also associated with facility reimbursement by payer, but it basically payment is attributed to that. What we like to do is look at how a facility is performing from a DRG, GMLOS perspective, because not only does it involve length of stay management, it involves patient throughput, care coordination, discharge planning, but it also looks at how we can help the cost of care in hospitals, basically hospital bottom line.
We were talking earlier before I interrupted you to get some definitions for operational definitions for the benefit of the group about the data and that you're looking at the data monthly. When that data is available, is that data published transparently, unblinded, or is it blinded of this is how I am, performing compared to my peers, and I can see that me, Nick Chmielewski, this is my performance, and this is David Broussard's performance?
We ultimately like it to be very transparent and very open, but it takes a while to get there. Providers by nature are very competitive. They're very highly functional, highly educated. And allowing them to see their own data is one aspect of performance improvement, but also applying their individual data to their peers allows them to see how they're doing as a group, as a service line. And I think our ultimate goal would be to produce these scorecards, distribute them monthly, and then have them discussed, whether it be in department meetings, whether it be at the medical executive committee level, the UR committee level, the individual peer evaluation level. And you take these scorecards and you look at them, and then you can determine courses of action from a positive perspective. None of it's meant to be punitive, and none of it is meant to focus on a negative outcome. It's all about possibilities of improvement and how we can make sure that we limit care variation, we improve patient throughput while not affecting quality of care.
I've heard that care variation sometimes may be a byproduct of actual or perceived institutional barriers. How can this be addressed, or how should that be discussed within the construct of looking at these metrics that you're discussing with the providers?
That's a great question, because there are internal and external barriers to every facility. So the external barriers are sometimes what they are, and we have not much energy can go to affecting those external barriers. But from an internal barrier perspective, perceived institution barriers are, it's always been done this way, or every time I ask, I don't get an answer, so I just do it my own way. And what the example that comes to mind is our antimicrobial stewardship programs, or how they've progressed over time, right? Over time, patients used to stay in the hospital and they have to stay there the extent of their antibiotic course, and then they would be discharged. When in today's world, most of our antibiotics or antimicrobials can be delivered in the outpatient setting. But a perception is that I need to keep my patient on these antibiotics so I can have a better discharge plan. From that perspective, all we would ask providers to do is reach out to your case management department, because the case management department will know exactly where these antibiotics can be delivered, how they can be delivered, and for the most part, the cost of that delivery. So extending stays from a perceived perspective, that's just one example that came to mind as far as institutional barriers. The other is access to imaging, access to outpatient testing. Like we talked earlier, there's perceptions that if I do it here, patients will have results quicker. But at the same time, it's not necessarily quicker. It's adding more work to all those departments that are associated with these extra testing. And that leads to longer length of stay.
What educational strategies are being employed or should be employed when you've identified this issue of, hey, listen, we've got all these great resources that exist in the ambulatory care setting. Here's the place patients can go for imaging. Here's the place patients can go for outpatient IV antibiotic therapy. Here's the infusion center. Here's how we can get them into the infusion center. We can take care of all of this, but yet there still seems to be this disconnect of we want to keep these patients in the hospital because we feel like we know that they're going to get it, where we don't really know what's going to happen once they get discharged. How do we bridge that gap as case managers or as hospital executives to give that information to the physicians, to the providers, and helping them understand the true outcomes that can be achieved and that no, it's not going to cause you to have a bounce back?
I think the primary goal from that question is to get introduced to your case management department. I think evaluating a case management department as far as its function and its productivity is important. I've been a case manager for quite some time. Arguably, I think case management is the most important department in a acute care hospital setting. Case management touches everyone every day, and understanding that if a case management department is proactive and they are begin communication with providers at the beginning of a patient stay, upon discharge planning starts at admission. I think if providers and case management begin their conversations on the day of admission, all of those issues that you just articulated can be brought up, can be answered, and a plan can be made, educated to patients and families, and then enacted when the patient's condition is warranting discharge. But you have to have a proactive case management department. You have to have a relationship between case management and providers. And you have to be able to be transparent and open communication so that both can go and educate our patients so that our patients understand where they are and where they're going.
How can a facility or a health system help with care variation without sacrificing quality?
Executives, they get the struggles of their facility. Our system executives understand where they want their system to go. But I think what we need our executives to do is understand that getting there requires some sort of change at times. And as you and I both know, culture is a huge barrier sometimes to enacting change. So the willingness to change can come from top down, having an accountable atmosphere. And once again, not necessarily a negative approach, but holding people accountable so that when those physician scorecards come out, or you can detect care variations, whether you're managing order sets or managing pathways or algorithms, and you can tell where some providers may not necessarily be following all the order sets as required, or the pathways not utilizing clinical care pathways as they should. Understanding that from a system or a facility perspective, asking the right questions, getting the data, and having those conversations and breaking down those silos so that you can improve.
What role does physician leadership play in length of stay management and underlying the various effects of care variation?
Physician leadership plays an important role, but physician champion is the ultimate role. And those two are not necessarily the same person.
Yeah, tell me more about that.
So most acute care facilities have a chief medical officer. They'll have if they have a hospitalist program, they'll have a hospitalist director. They'll have director of surgery, director of medicine. But sometimes within those departments, you have a high functioning, high performing provider that has great length of stay management, has great order set utilization, great relationship with the patients in the healthcare team. That person may be your champion versus that department lead who has a multitude of responsibilities outside of just monitoring the clinical care being provided and the acute length of stay. Selecting that hospital leader or that physician leader, that provider leader is important. And then once that champion is selected, making sure that champion has the ability to break down silos, whether it within case management or within his own or her own department, and in how they can perceive and address the issues within that department so that they can move forward. I think that physician champion is huge. And then also that physician champion having the ability to report into its leadership committees as well, from the medical executive committee and the UR committee. Those are two very important committees that can affect variation in a positive way and hold people accountable at the same time.
Any closing thoughts as we wrap up this episode?
This is an important topic to discuss because in healthcare, nobody gets into healthcare to do bad, right? We all want to make sure that our patients are cared for, and we all want to make sure that we have great outcomes. Mixing healthcare and care variations is important. And we all know length of stay provides us an opportunity not only to have patients progress through our system quickly, but that energy that we utilize to address length of stay, we also have to utilize the same amount of energy to make sure the next person has a bed available for them, because there's lots of patients in the community that trying to get into our facilities. But if we don't progress patients within our facilities timely, those patients won't get into the bed they need to get the care that they deserve.
Improving length of stay by targeting provider variation has been our episode topic. David Broussard, thank you so much for your time today.
Thank you, Nick. It was my pleasure.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.